Pastors Chooks and Toyin Ogoye. Pastors Chooks and Toyin Ogoye are the lead pastors of Resurrection Life Church, Johannesburg, South Africa. They are passionate about building families and raising men and women who transform and uplift the standard of life in their communities through understanding and applying biblical principles. Pastor Chooks and Pastor Toyin frequently host workshops, seminars, and conferences for transformation. Some of their programs include Kingdom Financiers Conferences, Dream Achievers Conferences, Marriage Enrichment Courses and Seminars, For Wives Only Seminars, Single Ladies Boot Camps, and Limitless Men Seminars. They are the founders of the Power of Women Academy, a group mentorship for high-impact women, and host the annual Power of Women conferences and amazing Power of Women broadcasts. For more information, please visit www.idelight.co.za and www.reslife.org.za or WhatsApp +27 814 210 835.
Good evening. Welcome to another edition of the Amazing Power of Women. I am Dr. Chucks Ugo here. And I welcome you to tonight's broadcast. This broadcast comes out of revelation that the Lord gave us the grace to capture in this book, The Amazing Power of Women. I published this book a few years ago. And I thank God for what He has done through this book for women's lives all over the world. And I want to encourage you, if you're a woman or you know a woman, that will mean anybody, you need to get a copy of this book. Very, very powerful revelation was captured here. Unlocking and harnessing her power within. Every woman has power that God has given to her. And not knowing what that power is or how to use that power makes you vulnerable for the attacks of the enemy. The devil watches out for women who don't know their power, who are unguarded around their power, and then he uses their power against them to hurt them and to hurt the people that they love. So we've captured that revelation here. And on this broadcast, we try to share around that power and just, shine light on the power, how to use that power well, how to protect that power, how to guard that power, and how to engage that power for the purpose for which God gave it to women. Part of that understanding has birthed what we call the Ask Your Gynae session. And this is where we bring in a gynecologist to help unpack several things around the health and the body of the woman from a physical dimension. We are spirit, we have a soul, we live in a body. And so the body part, we address it on Ask Your Gynae. And tonight is another edition of Ask Your Gynae. Ask Your Gynae comes once a month at the last Thursday of the month, which is today. And we are having once again the pleasure and the honor of our resident gynecologist, Dr. Audrey Gugu Gamedze, who has the practice here in Johannesburg, helping women on a day-to-day basis dealing with their health issues and gynae issues. So tonight, Dr. Gamedze is coming right after me now to share on something she started or to finish something she started on some episodes ago. She was teaching on antenatal care, how to take care of yourself when you're pregnant, the things that are important, the things that are necessary, and all that. And pregnancy is something that most women desire. Most women desire that at some point they will carry a baby in their womb. So if you are a woman, you've gone through baby rearing, or you are going through it, or you will go through it, it's important that you watch this broadcast and then share it with other women who will go through this stage in their lives of carrying babies. So you want to listen and then help a sister around you listen. Before tonight, the part 1 of this teaching had been done. So it's all there in our YouTube channel. Subscribe to our channel, like it, click the notification button so that when we upload new stuff, every Thursday we're uploading new stuff on Amazing Power of Women. And so you can get it. And then you can also learn the things that have been shared in past episodes, because the knowledge is not obsolete, it's not going away. So the things that have been shared, we've touched a number of things, so many things around the health and the body of the woman. So you want to go back to the channel and just go through, scroll through and see what tickles your fancy when it comes to the body of the woman. So I'm going to hand over to Dr. Gamedze. Thank you once again, Dr. Gamedze, for affording us your time, your expertise, your knowledge, and your wisdom to help women, and your heart to just help sisters around the world learn the things they need to learn about their body. We're talking about antenatal care part 2. Over to you, Dr. Gamedze.
Dr. Audrey Gugu Gamedze. Dr. Audrey Gugu Gamedze is a medical doctor by profession, a specialist consultant in obstetrics and gynecology. She runs her own private practice where she helps and serves women from all walks of life on a daily basis. She has a heart for women because she identifies, by virtue of being a woman, a sister, a mother, a wife, a daughter-in-law, and understands the journey of a woman and is still passionate about wanting to learn more about women. She is a born-again Christian medical practitioner. She sees her medical practice as a powerful ministry platform, an opportunity to touch and transform the lives of women and their families to the glory of God. Dr. Gamedze features monthly on our Ask Your Gynae show at the Amazing Power of Woman broadcast, where she helps women understand the female body and how to care for it. She's the mother of 2 children and has been married for over 22 years.
Good evening again, my dear listeners and viewers. Thank you again to be a part of our program, The Amazing Power of Woman, Ask Your Gynae session. A special word of gratitude to my pastors, Pastor Twain and Pastor Chooks, for allowing me and giving me the invite to be again on this session. It was a power-packed session the last time we spoke about antenatal care. We dealt in depth with preconception, counseling, and we did touch a little bit on antenatal care. So today we're just going to dive into depth and see what is the content of booking. When you're now in the hospital or with your gynae or with your midwife, whatever level of care that you are under, what does it entail? So antenatal care after conception is essentially what is called booking. It's booking visits in our South African language. So with your midwife and gynae, you will be going through the plan of care, and that is usually pertinent to the particular patient. I do want you to appreciate that when you come to your antenatal care, that kind of care is tailored to you. It's never one size fits all or a blanket kind of care. During that time, we're also able to demystify myth and also to define the practical and affordable plan of care with the level of care that suits your medical needs. So in South Africa, we've got what we call the antenatal record. That is usually a booklet that was devised by the government, including or with consultation with influential healthcare workers in the obstetric field. That entails the comprehensive care of the pregnant woman. So in government, you take this booklet wherever you go, and it is to encourage continuity of care, whether you are going across the provinces and even outside the country, that still remains pertinent to your care. The next doctor or the next healthcare worker will be able to know what was being done to you and what to watch out for. So it also assists one to devise a strategy around your delivery. So antenatal care is focusing mainly at the end game. When it is time to give birth, are we going to have a healthy mom and a healthy baby? So that is the target. So when you get to the first visit, one, we want to age the pregnancy and also to establish the number of fetuses that are in that womb. By aging pregnancy, we can use the last menstrual period, which most of us will not remember, or if we do remember it, we may remember only the month. So the history is important. Secondly, via ultrasound or establishing symptoms, we may be able to estimate the number of fetuses that you have. If the pregnancy is already advanced, we can measure the size of the tummy. Hopefully there isn't that much subcutaneous tissue, which can be deceiving when we try to establish the age of the pregnancy. So ultrasound is the gold standard in establishing the age of the pregnancy and also the number of fetuses. Mistakes still do happen, but in the right hands, we are likely to get the best result out of that. And then the second important thing, apart from aging the pregnancy, it would be to locate the pregnancy. In early pregnancy, we may find that the pregnancy is not inside the womb. It is not inside the womb. So history will help us to establish the possible site. Like if a mother reports that she's in excessive pain and also the pain is worsening, we start suspecting that the pregnancy may be located outside the womb. Also, from the size of the uterus, we can be able to tell if the pregnancy is growing inside the womb or outside. Let me make an example. If a mother has what we call a phantom pregnancy, when you examine that woman, you may not feel anything because the womb is not growing. It is only the psychological aspect of pregnancy that is growing. So what can go wrong around the location of a pregnancy? So we have had a session where we discussed at length about abnormal pregnancies. I'll just touch a little bit because we're talking about antenatal care. Sometimes we go to our various healthcare providers excited that we are pregnant and only to find that yes, we are pregnant, but the pregnancy is not in the right location. So an ectopic pregnancy is a pregnancy that is located outside the womb. It is commonly in the tubes, fallopian tubes. It can be in the ovary, it can be on the cervix, and it can be on the outside of the womb, an extrauterine pregnancy, and the pregnancy is floating in the abdominal cavity. So the second abnormal kind of a pregnancy that can be diagnosed will be what we call an anembryonic pregnancy. That is, yes, you are pregnant. Yes, we can see a sac inside the womb, but there is no baby. So that is called an embryonic pregnancy. It is a very distressing kind of a pregnancy if you are expecting and have been planning a pregnancy. You can also find a missed miscarriage or a missed abortion in gynecological terms. By the way, if we say abortion, we are referring to a non-viable pregnancy that is less than the age of 20 weeks. We say it is an abortion, not that we are implicating that you have destroyed the pregnancy. It's a gynecological term. We try to be modest in our language, but if you hear people talking about an abortion, please do not take it personal. So a missed miscarriage is when now we can diagnose the pregnancy, we can see the fetal pole, but there is no fetal heartbeat. The other common kind of a pregnancy that is of an abnormality or an abnormal location will be at what we call a trophoblastic pregnancy. That one usually gives you a positive pregnancy test or a negative pregnancy test in the background of a once positive pregnancy test. When we quantify, that is, we take blood tests to check the actual level of the pregnancy hormone, we find that actually the level of the pregnancy hormone is so high that the pregnancy test that you do in your urine cannot read the level. So it gets confused and give you a negative test. When we do an ultrasound there, we only see grape-like structures that are occupying the entire cavity of the womb. That will be a trophoblastic pregnancy. It is also a very painful one, or what we call a molar pregnancy. It's also a very painful if it is an expected and a planned pregnancy. Briefly, if it is an ectopic, you can be offered two options, which can be a medical treatment or a surgical treatment, depending on how far pregnant and if the baby is alive or dead. I just want to warn my sisters that if you have an ectopic pregnancy, please don't say to the doctor you want to go home and discuss it with whosoever, but instead just make the decision immediately, because it can be life-threatening, and also it can threaten the loss of the womb, the loss of the mother. Operation, they can cut you open, or they can use laparoscopy, which is a minimally invasive. In both ways, you are most likely to lose a tube. Only in medical management, you will not lose your fallopian tube. I'm dwelling on this because nowadays we plan pregnancies, and when we get an unexpected outcome when we go for our antenatal care, it becomes very much distressing. But when you already know from the Ask Your Gynae session that these are some of the unexpected outcomes that I can get when I go to the first checkup, it settles you to know that what is happening to you is something that is not outside what is known to humankind. If it is an anembryonic pregnancy, it can come out on its own. The commonest presentation will be an abnormal bleeding during pregnancy. Hence, my sisters, if you get that abnormal bleeding early in the pregnancy, please go and seek medical attention. In our government clinics, due to the workload, you may find that you get a very late appointment, or you get told to please go back home and come back when you are 5 months. But when you see any bleeding, don't wait for the 5 months. You can go to the nearest GP. Usually they do have ultrasound, and you can have your test done. With trophoblastic pregnancies, that one is usually a very serious health condition that cannot be managed in the clinic. You need to be transferred to either a district or a regional or tertiary hospital, depending on the extent of the pregnancy. So the mother will give a history of an abnormal bleeding or the passage of grape-like structures. On other times, you can find that the womb is growing a little bit faster than how far pregnant you are. So this kind of a mother will say that I am feeling so big. And when you go for your first ultrasound, they will not find a baby if it is a complete mole, or they may find a baby and an abnormally looking placenta if it is a partial mole. Also, the symptoms of pregnancy, they become so pronounced. If people are vomiting in the morning, you are vomiting throughout the day, you are feeling so tired, the accentuation of the pregnancy symptoms is always on the upside. So please do check if you've got excessive pregnancy symptoms, if it is a normal pregnancy. So some of these molar pregnancies, they can be cancerous. So it is very important that when you get cleaned out after the diagnosis, you follow up the results. And if they give you a follow-up appointment, please do honor it, my dear sister, so that you can be helped and you can know the histology of your results. If the level of the pregnancy hormone is now monitored after the pregnancy has been cleaned out and it is found to be rising, you may be referred for what we call chemotherapy. Please do follow up on that, because it can lead into a disaster when you get an extensive cancer of the womb, and that can go to your liver, go to your lungs, go to your brain. Yet if we had like stick to the follow-up appointment as per, that would have been averted. So you may find that you get serious levels done every second day. You may also get the levels of the pregnancy hormone monitored 6 months after, 3 months after. Please do adhere to that. It's very important. Okay, so that was about the location of the pregnancy, the number of the fetuses in there, and around the viability of the pregnancy. So also on antenatal care, we do what we call screening. We did touch out that we do screening for infectious diseases. We do screening for chromosomal diseases or abnormalities, and we also do screening for socio-economic circumstance. Let's unpack this further. The infections that we normally look at are sexually transmitted infections. We did touch briefly on syphilis. Syphilis is one of the sexually transmitted infections which is on the fading side of the graph now because of good antibiotic care, and also that we are now becoming more sexually responsible. Having said that, we still do see a number of affected women. So if we take blood, we do screening for syphilis. Why is it important? It can affect the baby. It affects the bony structures of the baby. So if a baby has got congenital syphilis, it's a baby that will have some abnormalities due to the affectation of the long bones by the syphilis bacteria. Rubella, which is German measles, it is not normally screened for in government, but it is commonly screened for in private. Yet it is a very common kind of an infection. This is commonly called German measles. So I would say people who work a lot with children, they must screen for German measles and they must be vaccinated. So if you get a rash during pregnancy, don't just go and buy lotion and start treating yourself thinking that it is just a rash. It must be tested what kind of a rash it is, because if you get German measles in the second trimester, it will definitely result in abnormalities on the baby. Hepatitis, we did speak around hepatitis. Sanitation is very important when it comes to hepatitis, but the B one is usually transmitted from body fluids. That is why it forms part of our sexually transmitted infections. So hepatitis can be screened as well, usually in private practice, but in government we will screen it if there's a history of contact, or also if there are symptoms like yellow eyes, or you are having excessive vomiting, we are suspecting that the liver might be inflamed, then we can screen for hepatitis. HIV, commonly in all HIV mothers, we do screen for hepatitis because we know that HIV usually opens the door for opportunistic infections. So HIV nowadays, we no longer ask for consent to screen for it in pregnancy, but it is a compulsory treatment, type of a screening, because we know we can have treatment and we can prevent transmission to the baby. Vaccines for all those infections that I have spoken about available except for HIV, of which I think medicine is moving very fast in that direction. So there are vaccinations that can be done in pregnancy. Those include pertussis, they include toxoid, they do include whooping cough. So let us make ourselves open to vaccination. There's a lot that has been said, which we might talk about some other day, around the contentions, around vaccination. So I think to take vaccines is a good idea when you are pregnant to prevent infections to the baby. But where possible, let's do our vaccines way before we fall pregnant at preconception counseling. Chromosomal diseases that we screen for, commonly it is trisomy 13, trisomy 18, and trisomy 21. That will be the Down syndrome, that will be screened in from the mother's blood. So this is done in threefold, of which every time we combine the three, we get closer to making a very strongly sensitive, specific kind of a test on history, on blood, and on ultrasound. So we offer this to all pregnant mothers. In government, because we are so restrained, you might find that it is according to age, but we have seen that the pathology of diseases has changed. It affects even younger mothers. So the first trimester, between 11, 13 weeks and 6 days, we do the first trimester screening, which will be the nuchal fold, plus the blood test and the history. It can incur extra charges, and medical aids do not pay for these tests. So if you have a history of abnormalities, or you are thinking that in your life you've been exposed in one way or other to things that can alter your genetics, it's very important to go through this screening. I love it because it prepares the couple or the family for the management of the pregnancy if they decide to terminate, or the management of the baby if they decide to carry on with the pregnancy. And also we are able to classify the pregnancy as to the level of care. Is it somebody who can stay at the clinic, or it's somebody who needs to be taken care of at a quaternary level of care? And also to plan around delivery. Is it there's a baby that we can deliver with only the obstetrician, or we need also the plastic surgeon, we need the cardiologist to be there, or we need to do the operation immediately the baby is born, or we need a fetal maternal specialist to do a certain procedure on the baby before birth. So it helps to have all those diagnoses done at antenatal care. So ladies, let's get out and seek medical care during our pregnancies. The disadvantage of this genetic screening test is that they are not informing us as to the level of affectation of the baby. Some of these syndromes are compatible with life, meaning that you can give birth to a live baby, although it's going to be a roller coaster taking care of the baby. And some other syndromes, they are just not compatible at all with life. Those that are compatible with life as well, they present in spectrums. The baby can be mildly affected, or the baby can be severely affected. In all of that, we may not know at which level the baby will be. So that's the disadvantage of the screening. It does not tell us the extent of affectation of the baby. But those that are incompatible with life, there's a lot of other abnormalities that can be picked up on ultrasound. Let me make an example of the severely affected Down syndrome baby. They can have holes in the heart. They can have what we call a cleft palate. They can have malfusion of the nasal bridge. There's a lot that can be picked up around the baby, which can help us to decide if we want to continue with the pregnancy or not. The third thing that we screen for is substance use and abuse. Nowadays, marijuana is in fashion, or it's fashionable. We want to know, how does that affect your pregnancy? Teenage pregnancy, we've got illicit drugs. Other moms are smokers. Other moms are severely alcoholic committed. So we screen for all of that, and we plan and advise where we can to say, if you can reduce quantities of this or that, the pregnancy can go a little bit more smooth. Also, we screen for maternal wellness. We did mention the last time about illnesses like hypertension, like blood pressure. This time, I'm just going to speak about structural abnormalities. This includes fibroids. It includes incompetent cervix. Incompetent cervix is usually diagnosed from a woman who gives a history of abortive outcomes or recurrent miscarriages. In our talk on recurrent miscarriages, we did speak at length about cervical incompetence and how we treat it. Because we are looking at antenatal care today, I will still highlight it because it's a very important component. So for some ladies, the mouth of the womb has a tendency to open up as the weight of the baby gets heavier. So if that is diagnosed at preconception or in early pregnancy, usually in the first trimester, we can put a stitch around the mouth of the womb. Later on in the pregnancy, you find that we've got less tissue now around the mouth of the womb that we can put the stitch around. And that also jeopardizes the outcome. Also, we've got the prostaglandins already started being more active. That can that can trigger an unstable uterus, resulting in contractions throughout the duration of that labor. And also, if it is done late, you find that rupture of membranes becomes a possibility now. So let us make sure that we know your history, and let us make sure that when you get to your healthcare professional, you share about your history of other previous pregnancies. In some cases, you find that the lady has had what we call recurrent ectopic, termination of pregnancy. Those usually we force the mouth of the womb to open. So that can result now in a lax cervix because it is used to be forcefully opened. So if you've had termination of pregnancies, it's not a taboo to talk about it. Talk about it that I've done 10 TOPs so that your healthcare professional is in a position to better take care of you. The other disease condition that I want to go a little bit deeper on, it is hypertension in pregnancy. Hypertension in pregnancy is responsible for a number of undesirable outcomes. This can be, number one, a very sick mother, number two, an early delivery or a death of the baby or death of the fetus. It is a very, very common pregnancy-induced disease. It is not related maybe to the stress level of the mother or the history. It can happen for the first time in a young girl who has never had a history of high blood pressure, who has never had any pregnancy, who doesn't even have a family history of blood pressure. So it may necessitate frequent visits. It can also necessitate additional medication. It can necessitate frequent admissions and frequent blood tests. It may necessitate early delivery. So if you have high blood pressure diagnosed antenatally, it is important to start preparing yourself that that pregnancy may not get to 9 months. The common tests that are done, they include blood tests, where we check the condition of the blood, because that blood pressure will affect the blood flow in your vessels. So we check that, and we also check the liver function, we check the kidney function, we also check your neurological function. Common symptoms include severe headaches, where you find that there's even blurring of vision. Some ladies start vomiting. Apart from the normal vomiting that happens in pregnancy, you can also have severe blindness starting after the raised blood pressure. So if you have been hypertensive, you will feel that this blood pressure is not what I am used to. The signs that we see, it can be a nosebleed, gums bleeding, you can have vaginal bleeding, you can have less fetal movement, hardening of the womb. Those are danger signs now. When you've got scanty urine, all pregnant women will attest that you go to the toilet frequently when you are pregnant. But in this case, you find that now there is less going to the toilet. And if you do go to the toilet, you will notice that the urine is black. It looks classically like Coca-Cola. Those are your danger signs that are saying, child of God, pack your bags and go to the hospital. So monitoring during high blood pressure includes the growth of the baby, the level of the water, and also for early signs of an abruption. Reduced growth is common, which is called IUGR, or reduced intrauterine growth retardation. It can include placental insufficiency, where you find that the placenta is not growing that well, it's not supplying the baby that well. All those symptoms can result in your healthcare provider suggesting early deliveries. So I have noticed in my practice that as soon as you start speaking about blood pressure, ladies get worried about admission. I prefer to admit. Admissions help you to be controlled and monitored. It doesn't necessarily mean that you are admitted to be delivered. But if this blood pressure starts later in the pregnancy, in your third trimester, the discussion with your healthcare provider will always be around delivery. And it doesn't necessitate cesarean section every time. If you are close to delivery, we will induce you. If it is in the second trimester, you are most likely going to have a cesarean section. So let us check our blood pressures. And if you already have the blood pressure, then please try to limit stress level, try and limit your salt intake, and also try to get enough rest. Take your medication. Take your medication. It's very important. Diabetes is another common disease that is diagnosed in pregnancy. I do want to make a very, very strong recommendation that even if your healthcare provider is not on the line of testing for diabetes, please do ask to be tested. Previously, we would know that it will be the well-nourished ladies, the people who are eating sweet things. We are seeing diabetes across the board. And the one that is pregnancy-induced is always specifically due to the pregnancy than what mom is eating. That one is cured, or the management may include insulins. It will always include tablets and also diet modification. When we say diet, people always think of a prescription that will say now you must eat asparagus, you must now eat cucumbers. It will help you to have a dietitian consult so that we know what foods are available at home and how can we best plan around what is available. So let's not be scared to go to our dietitians, because they've got a world of advice around how we can eat to control our diabetes. Then the last trimester care during the antenatal time. I am focusing on the last trimester because this is now when, with your healthcare practitioner, you voice out your desires, or you review the desires around delivery that you voice out. So we finalize the setting of delivery based on all the other factors that we've looked at. We also look at the growth and size of the baby. If you are a mother wearing a size 3 and your husband is 1.8 meters, there is usually less chances that that baby will be able to be delivered normally. But in the last trimester visit, that's when you'll be able to assess now the ratio of mom's pelvis to the size of the baby. We can also locate the placenta. Some mothers have a placenta that has a tendency to sit lower down and it does not migrate up. That will cause a lot of bleeding during delivery. So if the placenta is still located in the same place, we change plans. Also, we can finalize the presentation of the baby. Some babies are naughty. The last visit, they were coming nicely head first, and all of a sudden they have turned their feet first or bum first. So the last trimester visits help us to consolidate what we have been planning or what we've been monitoring, or how your progress has been in regard to the final day. So mode of delivery can either be normal vaginal birth, which includes assisted delivery. Assisted can be forceps, it can be vacuum, cesarean section, which can be done in the classical manner, or it can be done in the lower segment of the womb. What happens on the skin is not always the same as what happens on the womb. So what determines what happens, or the cut on the womb, is usually the circumstances once one has opened inside. And also, we are able to finalize the place of delivery. Some moms want to be in the water, other moms want to be in the labor room, other moms want it to be done at home. So we are able to finalize that on that last trimester. And also the level of care. Some moms need to be taken care of in quaternary hospital. Other moms, it can be done in the midwife clinic. We also discuss labor room etiquette, how you conduct yourself during labor, and also how we can best control pain during labor. I will dwell on that when we do our next lecture or our next discussion on intrapartum care. But there is pain care available for every level of pain during labor. So let's summarize. We have looked at antenatal care. Antenatal care and the things that can go wrong during the care, and how do we go about around those, and why it is important to subject yourself as a lady or as a mom to be to antenatal care. The purposes of this meeting, or the purposes of this session, it is to prime you to get out there, look out for care, and also to attend antenatal classes. Most of the things that we have touched on, the midwives who are running antenatal classes can give you more of information around that. So thank you so much for joining me again today on our last discussion on antenatal care. Stay tuned to our next discussion, the next session on intrapartum care. What's the labor ward etiquette? Till then, God bless you.
The Power of Women Academy is a group mentoring program for high-impact women. Women who want to change their lives and their worlds and move on to the next level. Power of Women Academy is aimed and tailored at unleashing the passion and greatness locked inside you as a woman as you walk the journey of life over the mentorship period with our team of distinguished and well-accomplished mentors from all walks of life. Our mentors are indeed destiny helpers. These mentors come to inspire you. They come to encourage you, to challenge you, to teach you, to stretch you, and to empower you. They are committed to helping you fulfill your highest potential and help you birth your wildest dreams that have been placed in you by God. For more information about the Power of Women Academy, please visit www.powacademy.co.za, or for inquiries, call 064 200 1545.